Ni hao to everybody, and thank you for having me today. My name is Paul Cottu. I'm a medical oncologist. I'm a breast medical oncologist, and I work at Institut Curie in Paris, in France. So the question with ER-positive, HER2-negative breast cancer at the early stage is whether we should use or not chemotherapy. And there are several ways to solve that, of course, genomic signature and so on. And there is another question which has emerged recently, is the role of CDK4/6 inhibitors in this particular setting and how we are going to articulate the chemotherapy and the CDK4/6 inhibitors. So that's why we devised the Ribociclib study, which is conceived to harness the neoadjuvant setting as it has been done in the HER2 or triple-negative field. And we use CDK4/6 inhibitors because we have shown in previous pilot trials, NeoPal and Coraline, that probably these drugs were at least as well as chemotherapy in this setting. So high-risk here was defined either by tumor stage, nodal status or tumor size, or by conventional high-risk features such as grade or Ki67, and in some patients, a genomic risk as evaluated on the initial biopsy. So we performed a 6-month course of Ribociclib plus endocrine treatment, and the result I have presented are the first result with regard to the result at surgery, where we measured the risk of recurrence based on the PAM50 ProSigna test, and we set a very specific threshold to define what is a low risk of recurrence in this setting. Again, based on the data that we had generated in the NeoPal and in the Coraline trial. And the spirit of the study is, in those patients who can achieve the risk of recurrence low score after neoadjuvant treatment, they will be spared chemo, and the main statistical hypothesis is on this subpopulation, which is the population of interest. So at this point, we have included 1,100 patients, which was the goal of accrual, but accrual was completed this week, actually. We present here the results on the first 686 patients for whom we have the data on surgery. So the purpose of this analysis is just to make sure that the proof of concept that was used to design the trial is reached. And indeed it is. The hypothesis was based on our previous data that at least 40% of patients should achieve a risk of recurrence low score. Actually, and this is the core result of this presentation, we had 52.6% of patients who have an error low score at surgery. So there are several steps that are already pre-specified. There will be a second interim analysis probably early next year, and the final analysis will take place in a couple of years because, again, the main endpoint, distant metastasis-free survival, not IDFS, but distant metastasis-free survival at 5 years in this population who can achieve this error low score. So this will occur probably in 4 to 5 years from now, and we have at least 3 separate interim analyses just to continue to make sure that the data are consistent and solid. And the second part is for the translational program, which is beginning as we speak, and we will have some presentation in the next months or years with regard also to the translational data.